Okay, it says we're streaming live on Facebook, so we should be able to go. Good afternoon, everybody. My name is Karen Huber. I'm with Home Instead in Cedar Rapids, and I'd like to welcome you all to the Caregiver Wellness Day. I'm a member of the planning committee for the Caregiver Wellness Day, and we have joined forces once again to bring this program to you virtually. This is our second month for 2021, although we did do this virtually last year. So we're becoming pros at this virtual program. Our virtual series will run through November. We will do it on the second Tuesday of the month at 1 o'clock. Today, we have a great program for you. In previous years, the Caregiver Wellness Day was hosted in person right here in Cedar Rapids. We have been providing invaluable information to our caregivers for almost 20 years now. So we didn't want to stop just because we had to do it virtually. We had to find a way to get it to you now. So Barb, go ahead and share what you have.
Well, good afternoon, everyone, and we're so happy to have you here again for the second part of our series. And I echo what Karen said. We're so glad to be able to offer this information in this format during these extraordinary times. I'm Barb Werning. I'm the Executive Director at Heritage Area Agency on Aging. And yeah, we've been involved in this event for 20 years. I'd like to take an opportunity first to thank Karen and Home Instead Senior Care for their part in supporting this event and making it happen. It couldn't be possible either without the endless hours and the services provided by all of you as caregivers. We thank you for everything you do for your loved ones. It truly is a task of love, and we hope that today you feel that care surround you as well. We also would like to, excuse me just a minute. We would also like to thank our sponsor today, St. Luke's UnityPoint. All the dollars from our sponsor are deposited into Heritage's family caregiver funds to help pay for the needs and services to help caregivers continue to provide care for their loved ones. Before we begin to speak with our sponsors, St. Luke's UnityPoint has a commercial to share with us on this wonderful day.
Okay, I'm going to do my best to share this commercial.
Yeah.
Is that showing up there?
Not quite. Karen, we're hearing pieces of it, but I don't believe we're seeing it.
Oh dear.
Through a lot together. We all know sometimes it gets hard, but it's okay to not feel okay. You know what helps? A good book or going for a walk. Not now, Fred. But what really helps is to talk to someone. Because to take care of each other, you gotta take care of you. If you need to talk to someone, your doctor will listen. UnityPoint Health. Know how much you matter to this world.
That little boy's so cute.
I know, it's adorable. Well, thank you again to UnityPoint St. Luke's as our sponsor for today. We'd like to introduce now our speakers for the event this afternoon. Jane Dohrmann is from Iowa City Hospice, and Dr. James Bell from UnityPoint Palliative Care will be discussing honoring your wishes and making a plan for end-of-life care. We're going to start first today with Jane Dohrmann. Jane is the Program Director of Palliative Care Services, which includes Support Care and Honoring Your Wishes program. She's worked at Iowa City Hospice since 2003. Jane was recognized as a change agent through the John A. Hartford Foundation for her collaborative work with iPost implementation in nursing homes. She's a state representative to the National POLST organization and serves on the NHPCO Palliative Care Council. She's married and she has one adult daughter. Thank you so much, Jane, and I'll turn it over to you to get started today.
Thank you, Barb. Hopefully everyone can hear me. I am in my work office here in Iowa City. want to thank you for the opportunity to spend this time with you. And I also want to thank all of the caregivers out there, personal caregivers, family caregivers, professional caregivers, for all that you do each and every day. It is a true commitment and a demonstration of how we care for one another, for folks in our community and for people in our personal lives. So thank you. First part of our presentation is about healthcare planning. And so when I talk to families and individuals about this, I really encourage them to think about what matters most. And usually the response I get is either family, friends, relationships, something of that nature is how people respond. When we think about healthcare planning specifically, I think we all want our family, our people that we love, to get the best care possible. We want folks to get the right kind of care at the right time. And when they are close to the end of life, we hope for a peaceful passing and that they feel supported and comforted and loved and ready for that next journey. So as a caregiver, I am a caregiver. This is my family. I have been in various caregiving roles. Most of us have been or will be at some point in our lives. I'm a mother. This is our adult daughter, and this is my father. And I am in a caregiving role with him currently. So as a caregiver, I ask myself, what can I do now to make it possible for the people that I love and care for in terms of planning and healthcare planning? We can't do everything. We can't plan for everything, but we can take steps now to make it easier each day as a caregiver or in an emergency or as someone declines. So let's talk about that a little bit more. What is advanced care planning? The one word that I encourage folks to think about is that it's a process. It's not a one-time event, but it is a process as we age, as our values and beliefs change, as our health changes. We want to have ongoing conversations. So that is another really important message that I like you to take away. It's important to talk and to revisit. And then we want these conversations to take place in the context of your values and beliefs, what's important to you, and then ideally create a plan, a written plan that states your preferences and that prepares others if they need to communicate on your behalf. We want those the statements that you make to express your values and beliefs, so that if someone needs to speak on your behalf, they will be able to be your advocate. I also think it's really important to recognize that there are different stages of planning, and that really this is a lifelong process, at least when you get to be about this age. This is our daughter when she was 16. I share with you briefly that I had done what I felt was my due diligence as a parent when she wanted to get her permit and her driver's license. Took her to all the classes, she prepared, took her to get her license, and then they said, "Do you want to be an organ donor?" And she looked at me and she said, "Do I want to be an organ donor?" And so we talked about it then, but we hadn't talked about it before then. So that was kind of the beginning stages of helping her think about these sort of things. My hope is that eventually it will be a cultural norm for all of us to have these conversations. When someone reaches the age of 18 and they have decision-making capacity, they have the right to complete an advanced care plan, an advanced directive specifically, and to choose who they would want to make their decisions for them on their behalf if they could not communicate. So I encourage everyone to complete a healthcare directive, and that's the initial part of planning. So not only everyone needs it, especially caregivers need it in addition to the care recipients or the people that you are caring for. So think about that. What does advanced healthcare planning include? I think it's a process of reflection, thinking about your experiences and values, discussing your cultural, religious, and personal beliefs that might impact the choices that you make about your care and treatment. Another piece to this is discussing the type of medical care you would or would not to have if you have a severe permanent brain injury. This is part of initial advanced care planning. The reason why we encourage this is because there's been a lot of conflict in our country, especially over the last many years, because people didn't plan and people didn't know what that person might or might not want. And it can be very stressful, and it can go on for many years with family members. So it's helpful to think about that question too. But I think one of the most important things that you can do is carefully select a person to make medical decisions for you on your behalf if you can't communicate. That's who the healthcare team is going to turn to, and they're going to ask, if Jane could speak, what would she want now? And so I would want my advocate to be able to answer that question to the best of their ability. That person becomes a part of the healthcare team when you can't speak for yourself. So what type of advanced care plans exist? There's different terms that you'll hear. One is a medical power of attorney. That's who I just mentioned, or a durable power of attorney for healthcare. That's the legal person who can make those decisions on behalf of someone. A living will is another commonly used term, and that's for people who are actively dying or have an untreatable disease, and what their wishes are related to that. iPost, you may or may not have heard about. It turns healthcare preferences into a medical order, and it is for people who are seriously ill or frail or elderly. It stands for Iowa Physician Orders for Scope of Treatment. You may have also heard about the Honoring Your Wishes Healthcare Directive, which is a medical power of attorney or durable power of attorney for healthcare plus is kind of what I call it, because there's also a place for people to write down their values and beliefs in their own words and what they would want their family or designated healthcare agent to know and to reference. And our tool has been around for several years now, and it has been at the center of conversations sometimes, saying, well, what would this person say if she could? And it is referenced as a tool in decision making. So when I start having conversations with folks about planning, I like them to reflect on their personal lives and their stories and what they've learned, because that's going to affect what you might or might not want to have. Some of the responses I get sometimes are, oh, this person, my friend, had this amazing experience and family was with them and they passed peacefully. Or I might get, oh, I do not want to die like Uncle Joe died. And then I ask them to tell me about that and what that means for them and what they've learned. So I encourage you to think about that. Another question that comes up a lot, and you'll hear this in different ways, what we like to use is, what does living well mean to you at this point in time in your life? What does that look like? What does a good day look like? What does a good day look like for the person you're caring for? How has that changed? Our goal should always be to help people make the most of each day, and hopefully help them have a good day or a great day. So something to keep in mind as we kind of have that frame of reference and plan for next steps. So I mentioned that it's also really important to think about your beliefs. What do you believe, and how might that affect the type of care or treatment you would or would not want? Some people respond to me very quickly and have a response or a lot of things they want to share about that. And some people say, you know, I don't know, I don't think there's anything I can think of, and that's fine. But it's a part of that conversation, and we want to respect and honor people's beliefs and preferences and what that means in terms of care. So I mentioned what a medical power of attorney is, or a durable power of attorney for healthcare. The other language that I use that is simpler is a healthcare agent. People will ask me, who should I select? Do I have to select my spouse since I'm married? No, you don't have to select your spouse. Many people do, but that is a choice, and it's a very personal choice. And I encourage people to think about your relationship. I encourage people to think about if you trust that person, and if you can have conversations with them, ongoing conversations as things pop up. Is it respectful? I like people to ask the person if they're willing to take on that responsibility. You may be amazed to find that some people don't even know that they're a medical power of attorney, and they've never talked to that person. We want them to be willing to serve in that role. We want them to be willing to say, yes, I will follow your wishes. And then a trickier one that makes people think often is, I say, how does this person respond in sometimes stressful situations? Because if they don't respond well, that might not be someone you want to select. The main thing is that they are thinking about your wishes and what you would want, not what's happening with them and how they're processing the experience. So some factors to consider. And then I always encourage folks to have an alternate as well in case that designated healthcare agent can't be contacted. So I mentioned honoring your wishes. Our form is on honoringyourwishes.org. So I encourage you to check that out if you would like. The important thing again is those conversations. So some people say, I already have a form, I'm fine with what I have, but what kind of conversations should I start to have? So on our document, we have some questions or things to contemplate, which might be a way for you to start conversations. And again, they're related to values. What makes life worth living? We will all live until we die, and there are various choices that we can make along the way. So that's why they are here, for that opportunity. My beliefs about when life would no longer be worth living, this is often referred to, or in terms of the severe permanent brain injury. Sometimes people will say, if I don't know who I am or where I am, I would like to allow a natural death. So that's one of the things that we talk about when I do advanced care planning facilitations. Another question is my thoughts and feelings about where I would like to die. We can't always control that, but if possible, sometimes people will say, if possible, I would like to die at home, which is the majority of the people in the US respond that way. My response is, well, perhaps you could put, well, with the help of home health, or with the help of hospice, or with the help of supports in the home to make this possible for me and my family. Again, starting that conversation will make it more likely that those supports will be in place. And then lastly, the form gives folks the opportunity to write something that they would like their family to read if you could not speak. And sometimes this is a very powerful tool for folks as a way to express their love and their gratitude for their family. So that's why we offer that. A few other resources I'd like to share with you is the book, The Conversation. These are some other questions that Dr. Valandis writes about in his book. Again, values, what's important to you, what are your fears, when might there be too much medical treatment, when you'd want that to stop, and what else you want your team to know. The same with Dr. Atul Gawande. This is a very famous book, and there's also a PBS documentary, which I would encourage you to watch if you haven't. But again, what are your hopes? What are the trade-offs you're willing to make or not make? These are important questions to ask along the way, especially if someone has a serious illness. Then the next step is to have those conversations with family. Sometimes it's around a dinner table, sometimes it's on a walk, but talking about what it means to live well and what's important to you. And then to share that with people in your circle of support, whoever that might be. And then create a plan and share that plan with your healthcare providers, with the people that you've selected to be your healthcare agent or alternate, etc. Folks that you want to help make sure that they will follow your wishes and that your wishes will be honored. I briefly want to mention iPost because it is an option for families, and I think it's an important one. If you are caring for someone who is seriously ill or frail or elderly. This became Iowa law in 2012. It is specifically for this group of folks. It is not for everyone. So it is not intended for a healthy adult. But it is a medical order that can be signed by a physician assistant, an MD, a DO, or a nurse practitioner. And it is important to have this offering as a way to help ensure that people's wishes are honored. We can't assume that everyone wants to be full code or have full treatment. That is the default, understandably, in our healthcare system, but at different times in our lives, that may not be what people want. And so those conversations need to be deeper. And there's a form that can be completed that EMS can follow in a person's home or in other healthcare settings as well. It's also used as a communication tool so that conversations don't have to start from the very beginning when someone is transferred from one care setting to another. Another book that I want to reference is The Art of Dying Well. And this is a great book. It's very lay friendly. I recommend it if you want to go a little deeper in terms of reading. So Katie Butler talks about the importance of being an advocate and asking questions if you're a caregiver, and planning for increasing supports as someone declines. More support could be needed. She also talks about the importance of being in charge, asking questions, and I really encourage folks to ask as many questions as you want. It's incredibly important that we do our best to answer your questions. I want to share an example of that. When my mom was ill, I visited her. She was in the hospital. She was a cancer survivor. She lived for 16 years with liver cancer. She was amazing. At the end of her life, she was hospitalized, and when I went to visit her in another state, I asked what her code status was, that meaning CPR or DNR. She would do not resuscitate. And she said, well, it's do not resuscitate. And I turned to the nurse and I said, could you please tell me what my mom's code status is in the chart? And she said, it's CPR. And my mom said, that's not what I want. And I said, let's talk about this and let's get that changed. And so we did. If I hadn't asked that question, things might have gotten harder, but I was glad that I did. So please ask questions as you advocate for folks, especially for people if they have a serious illness or injury. We want to help make sure that everything is in place. So something to think about. Lastly, I just want to mention my great-grandfather. He was a wonderful man. He died when I was 12, and I remember him looking this way, with being in a suit with a hat. He had a wonderful long life. He went to church one Sunday, came home, sat in his favorite chair, took off his hat, and passed away. that was a very smooth transition, I would say. But the reality is that most of us won't die like that in the United States. And it's important to have these conversations and resources to think about how to have a positive experience at a delicate time in one's life and for one's family. Palliative care is a resource for people who are seriously ill or have a serious injury. And Dr. Bell is going to talk about what that looks like and how that might be beneficial to you and those you care about. So, thank you.
Well, thank you, Jane, for all of that information and sharing some of those really heartwarming family experiences. We appreciate your presentation so much. I'd like to remind all of the folks watching today that if you have questions, if you're online on a computer, you can kind of scroll down at the bottom and you'll see a little chat box. It looks like a little word bubble. If you click on that, you'll be able to type your question in there and we'll be able to get that later and answer those. Or if you're watching Facebook Live, I think you should be able to just type those questions into Facebook as well and we can address them later after the second presentation. And now we'd like to move on to Dr. James Bell. Dr. Bell is the medical director for palliative care at St. Luke's Hospital here in Cedar Rapids. He completed medical school at the University of Iowa and family medicine residency at Cedar Rapids. He's board certified in hospice and palliative medicine, as well as family medicine. He practiced family medicine in a small group in Marion from 1986 to 2008, during which time he served as hospice medical director and assisted with formation of the palliative care program at St. Luke's. Since 2008, he has served full-time in that role. He enjoys jogging, fishing, jazz piano, and being a grandfather. So thank you so much, Dr. Bell, and I'll turn it over to you.
You bet. Am I sharing my screen the right way? Can you guys all see it?
We're seeing email right now, Dr. Bell.
Oh, isn't that lovely? Let me just go back to something else. So I apologize. I'm a neophyte at there. I'm going to try to share my screen again. How's that?
There you go. You're on.
Right. And I think I know that this isn't as clean as what Jane had up, but I'm going to leave it up just so that I don't blow something else up. I'm pretty well known for making things go black. Jane, you did a really nice job of introducing the concept of palliative care. And I'm just going to kind of briefly go through the essential elements of palliative care for you. It's still a phrase that a lot of people are confused about, and even the people who do it have a hard time sort of defining it sometimes. But as caregivers, here's how I would say that you want to think about palliative care. Palliative care is something that happens or should happen when people have serious illness, things that are potentially life-threatening, and there's some conversation that needs to happen about choices and about the quality of life filter in that conversation. So sometimes people confuse palliative care with hospice. Palliative care is not hospice. Hospice happens when we know that the end of life is coming into view and that our job is to just keep somebody comfortable. But before that, a lot of people with serious illnesses, and we'll go through some of those, have time in their life when things can start happening that theoretically could bring the end of life into view. And just like Jane was talking about, you want to think about not the amount of time, but the choices that they have in the life that they're fighting for. That really is probably a very brief definition of palliative medicine for you. And again, as caregivers, what you are concerned about is making sure that you are representing the desires and the choices of your loved ones and helping to implement those the best that you can. So these are the different things that we do. Heart doctors have a heart catheterization, and kidney doctors have dialysis, and palliative care doctors have a family meeting. And the main thing that we do to help understand how we're supposed to take care of somebody who has serious medical illnesses is to sit down with every stakeholder, including you as caregivers and including the patient, whenever they can be part of that, and to have that conversation around what is the patient exactly fighting for. And we want to think about that in a team sort of a way. So I'm the doctor part of the team, but we have social workers and pastoral care when that's important, and volunteers to help to sort of round out that conversation. We talk about all these different things, such as things that make people feel bad. So one of those is pain. We do a lot of symptom management. We talk about the kind of things that Jane was just explaining to you. If a person was found without pulse or breathing, would they want CPR? Would they want to be on a life support machine? How do they feel about being in an intensive care unit? Have they completed those advanced directives and the power of attorney? And then again, the psychosocial and spiritual issues, which are really key to you, again, as caregivers. So we'll go through kind of some of those things again, maybe in a little bit more detail. These are the sorts of diagnoses and the kind of situations that we see people having, combinations of all of these that commonly occur as we age and as we see people sometimes in and out of the hospital or in and out of a doctor's office more often. This isn't always older folks. We actually take care of children, and we even do perinatology with pregnant moms who have situations that are potentially life-limiting illnesses. So we take care of all age groups, but by and large, we take care of older folks with cancer, heart problems, lung problems, kidney problems, dementias, or strokes, and multi-system disease. Right before I came here today, and by the way, I'm at home because St. Luke's doesn't support Zoom. So that's one of the reasons I'm a little bit technologically challenged, and that maybe my voice isn't coming through as loud and clear as I would have hoped to. But right before I came home today, I met with the family of a 96-year-old man who lives at a care center, who before he fell was getting around well, taking care of himself, getting to the bathroom, getting dressed, doing his own toileting at the care facility, but he fell yesterday and broke his hip. That's a game changer for people, and you need to think about the choice then of, am I going to have that hip fixed? And so again, we sat down with the whole family to have a conversation about what would it look like if he didn't fix that hip, and what would he be fighting for if he did. So those are the kind of situations that we sometimes get ourselves into. When I mentioned goals of care, this is really some of the things that you all know about and you all face. So it's issues of independence, and when people are threatened with their world shrinking by moving into an assisted living environment or a nursing home environment, what does that really mean to them, to their life? For some people, it's fine. For some people, not so much. Cognitive issues and issues of dementia are really common, probably unrecognized a lot of the time. And we tend to, for some strange reason, kind of separate those out from medical problems. But you really need your brain to tell you what to do in a situation like recovering from hip surgery. So if it's not going to tell you what to do very well, then it's a different conversation. We get into situations with some illnesses where people are facing breathing support, feeding tubes, dialysis, being in and out of the hospital, and where those things that are happening really do make a difference to how they want to live their life. So those are some of the things that we talk about. Again, I mentioned that sometimes people suffer, and we tend to spend our time trying to fix problems and not always thinking about what's making them suffer. And so when people feel like they are struggling to breathe, or they have pain, or nausea or constipation, a lot of times in palliative care, we're helping to deal with those kind of situations. Jane already went over the advanced directive and the living will part of this and the I-post very, very well, so I'm not going to dwell on that. These are important things to you guys, the psychosocial issues that many times are really dominant in family systems. And again, I'm not telling you guys any secrets. There are dynamics. We all have we all have oddities. We all have things that make our families interesting and curious and wonderful and sometimes scary. And so those things sometimes lean into medical decision making. One of the things that we do in palliative care often, unfortunately, is to be the ones to break bad news. And sometimes truth telling in medicine can be really, really challenging, because if it's hard or if it's bad news, sometimes it's just easier to not talk about it. But it's important to talk about it because it's the way to be respectful to your loved one. Financial issues oftentimes are very important for people. What does it cost to be in a assisted living environment, or what is the difference between skilled nursing care and an intermediate level of care? So we have to go through all those kind of things. How people deal emotionally and struggle sometimes with anxiety or depression as a part of a significant illness. So we're talking about all those sorts of things. I put a slide in about spiritual issues, and sometimes that can be sort of a hot button because people can sometimes associate that with labeling or religion or a specific kind of a church, or maybe pressure to proselytize or to twist somebody's arm into thinking a particular way. When we talk about it in palliative care, it's really about where a person finds meaning and purpose and strength, and whether there is a sense of peace or whether there's unfinished business. If they're looking at the potential for end of life to come into view, is that a place where they're settled and comfortable, or is that a place where they struggle and there still needs to be some help there? And again, that sometimes very directly influences what we do as doctors in medical care. So it's very important for us to understand that part of things for people. I already mentioned this a little bit, but just to sort of loop back and say it again, palliative care, and we are actually the newest specialty in the country. Palliative care has only been in existence for 15 years or so, maybe close to 20 now. But palliative care sort of arose out of the reality that in America, we don't always do a great job when people are coming near the end of their lives with helping them to think about their choices in a way that puts the focus on quality of life. And when we have hospice care, it really sort of puts people in a little box where they can no longer seek disease-directed treatment for the kind of things that I listed for you. So people on hospice care are not generally getting cancer chemotherapy. They're not generally talking to their cardiologist about doing a lot of interventions. They're not in and out of the hospital fighting infections with strong antibiotics. But in palliative care, all of those things can happen, and they may or may not be part of good care depending on what a person is fighting for. So that's the way to think differently about palliative care than hospice care. So I know I went through my slides pretty quickly there. I did that kind of intentionally so that it would give everybody time to ask and that we can answer questions. So if it's okay, I'm going to give you back that time.
Well, and thank you so much. Thank you so much, Dr. Bell. Appreciate all of that great information. We did have one question for Jane or also for Dr. Bell. When should end-of-life planning begin? And how do I start the conversation with someone who doesn't want to talk about it?
Well, if they are not ready to talk about it, that might not be a good time. I do think setting an example is also it's a great way to begin that conversation. So stating why I, for example, completed a healthcare directive and why this is important to me, and perhaps hopefully to that other person, that it's a gift to them, because we don't ever know when we might be in a car accident, when we might be in a bicycle accident. Helping people think about their experiences and how that has affected them can be a great starting point for that conversation. And the why. The why is it important to me? So for example, it's important to me that we talk about this and that you think about completing the healthcare directive so that I can do what you want, so that I can make sure that I can be the best advocate for you. We have to get into a position of vulnerability, and sometimes that can be comforting, but uncomfortable, but in some ways it could be comforting in the sense that we're expressing how much we care about that other person, and maybe that can be in, those suggestions can be ends. Dr. Bell, do you have something you want to add to that?
Yeah, no, I think that was a great answer. And you also did a good job of this when you were talking about the iPost. And again, I apologize. I know that my audio is not coming through really well. You know, everybody should have an advance directive. Not everybody should have an iPost. People who need an iPost are people where those kind of questions might need to be answered pretty soon. All of us should convey to our loved ones to some degree what in your imagination, how you would want to be cared for if you were in that kind of a situation like Jane was talking about, a bad car accident, you know, something disastrous that happened. Those things are obviously relatively uncommon. They're very unpredictable. And if you just sat in your living room and said, how likely is it that I'm going to get run over when I walk outside my front door today? It's pretty unlikely. But then sometimes there are clouds that start to appear on the horizon of healthcare. And it's not so surprising when things start to happen that maybe a little bit more predictably might bring this kind of a conversation into an important area. And so there's actually kind of an idea that they sort of labeled death over dinner. And one of the recommendations that sometimes people like Jane or we would make is go home and sit down and talk to your family and have a nice dinner. And even though it's kind of awkward and uncomfortable, think about everybody expressing to their family how they would want to be cared for in a situation where they might be facing some of these critical things like life support machines and things like that. And really what that's a talk about is what makes my life good and what makes it worth it for me, and what would I be fighting for in that kind of a situation. So I would never discourage anyone from thinking and talking that way. You don't necessarily need to get really, really specific about that until things probably start to come into a little bit clearer focus.
Another approach that I've taken sometimes is to ask someone if they have car insurance, and if they drive. And most people have car insurance because in the unlikely event that they would get in a car accident, that would be in place to assist. Well, this is just a different type of planning. We don't ever want to get in a car accident, but it could happen. And this is a way to take care of ourselves and to care for one another. So perhaps that would be another approach.
I've had another question come in. How does the ambulance service know I have an iPost if it is home on the fridge?
Mm-hmm. This is why you have to have an advocate, and they may or may not know. The EMS probably doesn't know if you're out in the community. Sometimes people carry their iPost or have a copy with them, which is still legal and valid. But in a sudden event, the EMS is not going to know. And so as soon as your advocate can share that information, the sooner the wishes are likely to be honored. So a person might be taken to the hospital, for example, if you're in a car accident. And then as soon as people are contacted, then that's when those wishes might be shared. But if someone's living in some sort of health care facility, like a long-term care facility, they should have those orders that iPost. And then if that person is transported in an ambulance, our ambulance providers usually ask, is there an iPost with that person? Because in long-term care, that's more likely. So that's how they would know.
Yeah, I can add just a couple of things to that too. So depending on the area of the state that you're in, that may be a better odds or worse odds that an iPost is going to be looked for and found and followed. So if you live in Lynn County or Johnson County, I can tell you that the EMS system is very well hardwired to look for an iPost and find it and do what it says. So you're very fortunate if you live in Lynn or Johnson or one of the surrounding counties. The second thing is this, that the reason that an iPost is there is to give guidance and direction. And the question is, what's the likelihood that you're going to get the kind of care you want if you're in a situation where somebody needs to know that? If you do not have an iPost, the chances are probably about 20% that you're going to get what you want, if it's not full complete treatment. If you have an iPost, it's more like 80%. So regardless of the fact that, if you're at the grocery store and something bad happens to you, there's going to be a little bit of a challenge, maybe an understanding that you're much better off if it's appropriate for you to have an iPost, to have one than not have one.
And I'll just add from, since our clients are in their homes and we see them on the refrigerator, we have had clients receive emergency care through EMS and they go right to that refrigerator and look for the iPost. And so I feel, in our communities, Lynn and Johnson and surrounding areas, they're trained to go to that refrigerator and look for that iPost.
Oh, do we have any other questions, Harrison? Any other questions from our Facebook Live feed? I'm going to make sure we give everybody adequate time. I'm not seeing anything, however. Okay, it looks like that's it. I'm so sorry, Jane.
No, that's fine. I was just going to share one other piece. In Johnson County, at the Joint Emergency Communications Center, if you have an iPost and you want them to know, you can contact them and they will connect your name with your address and your phone number, so that if EMS is going to that home, then a little salmon colored flag pops up in their system to know to look for an iPost. In case it's not on the fridge, they will ask. So none of these types of planning are foolproof, but they all help. They all really help to make sure that wishes are more likely to be honored.
Any other questions from those of you listening in today? Doesn't seem like it, but I'm sure they may come up later. So for today, we'll say thanks again to our speakers, Jane Dohrmann and Dr. Bell, on this really important topic. Both of our speakers today have their contact information on our website. If you have a question later, you can certainly reach out to Heritage or to them. We'll do our best to make sure your questions are answered. Also, a huge thanks again to our sponsor, UnityPoint St. Luke's. And thanks again to Karen and Home Instead Senior Care. We will be saving our webinars on our website. You can find that at heritageaaa.org. You can look there and they'll be saved for until the end of the series in November. So feel free to go back and re-review. And again, we'll do our best to answer any questions for you if they come up later. Anything else to add before we end the day?
Barb, I might add just one more thing, and that is people listening to this could be wondering, how would I access palliative care? And maybe Jane wants to say, how would you access your service as well? So we require a physician referral, and if you feel like you, your family member, your loved one would maybe benefit from palliative care, I would just encourage you to talk to your primary care physician. We have palliative care inside the hospital and outside the hospital. So I have a nurse practitioner and a social worker that helps people that are in the community to support them very similarly to how we do in the hospital. So I would just talk to your primary care physician or clinician and get the wheels turning if that's something that you feel is appropriate.
Mhm. I would agree. And where I work at Iowa City Hospice, we have a home-based palliative care service. So it depends on the context of where you're receiving care. At the university, they have hospital inpatient palliative care, like Dr. Bell has referenced, outpatient palliative care services. And then where I work, we offer home-based palliative care. So having those conversations with your primary care provider is important. If you have any questions, you're always welcome to call us.
Anything else before we close the day? Oh, Karen, I'm so sorry. Well, again, thank you both for speaking today. You brought so much information to our group. We appreciate it. We will see you all next month in September. And until then, I wish you all well. Thank you for coming and have a great day. Stay cool.
Thanks, everyone.
Bye-bye.